now. So I'm going to do a quick lightning learning on actually HSP, which is now known as actually IgA sort of a IgA vasculitis. It'll be very, very quick. I'll try and be as sort of interactive as possible. And I need to thank Anna, because Anna basically put some of these slides together originally. So this is often what you actually get. You're working in A&E, covering sort of the admissions unit, and you get a GP referral. Can you please see this child? I've given a 5-year-old girl who's coming with this sort of purpuric rash in her legs and buttocks. She's complaining of knee pain for the last couple of days. And what's sort of likely sort of diagnosis people are actually thinking at this actual time? Anyone want to hazard a guess other than just sort of HSP? So yeah, HSP is always at the top, is always one of the things you need to think about. So quickly, what is actually HSP? It's the most common vasculitis in childhood. It's a multi-system small sort of vessel vasculitis. It most commonly affects children, which the age between 2 and 6. Very interestingly, it does have a racial sort of predominancy. It's more common in Asian. You get basically about 24 per 100,000. Caucasians about 17.8 per 100,000, and then Afro sort of Caribbean children are right down there, sort of 6.2 per 100,000. The actual pathogenesis is actually unknown. It's supposed to be polygenic, and it's due to an abnormal IgA, and IgA is a major antibody. Was present in most of the mucosal secretion. It is the first line of defense against most actual pathogens. And interestingly, it does show a seasonal sort of variation. So you will see more in the sort of winter, early sort of spring. How it actually how do you actually diagnose IgA? What sort of workup? Well, IgA is basically a sort of purpuric rash. It's most commonly in the sort of lower sort of limbs, and the buttocks and legs, and you need to have one more of the other ones: abdominal pain, hematuria, proteinuria, acute arthritis, and if you were going to stain any tissue, you would have IgA staining on biopsy, and that's very, very rarely, if ever, done. But and what you need to actually do is basically do a quick workup to try to basically exclude other things such as sepsis, ITP, NAI, and sort of actually DIC. And the sort of investigations you should include are FBC, clotting, U's, a urine dip, a blood pressure, and if your actual urine dip is positive for protein, if there's any proteinuria, you should send a urine sort of protein creatinine ratio off. Now, what everyone wants to know is when do we admit? When do we actually discharge? When do we actually speak to a tertiary team? So the management, the actual majority of these actual children are treated actually symptomatically. It was rest and analgesia. When do you admit them? If the child has significant edema, if their pain can't be controlled with simple analgesia, I mean, you can't get quite severe joint pain, quite severe abdominal pain. Any evidence of actual GI sort of hemorrhaging, neurological symptoms was exceedingly rare, and actually pancreatitis. When do you want to refer? I work in actually nephrology. When do we want to know about an HSP child? We want to know about HSP child if their actual eGFR is less than 90 mils per minute per meter squared. And there's a very easy formula, because a lot of a lot of trust sort of actual computers don't actually do EGFR for children. So there's a formula we use, which is 30 times the height divided by the serum sort of creatinine, which gives you an estimated EGFR for the children. If the actual blood pressure is raised, a hypertensive child, if their albumin is less than sort of 30, if the urine protein creatinine ratio is greater than 100, if the macroscopic hematuria, then you should refer to or at least speak to the actual your sort of local sort of nephrology team. If there's any surgical concerns, if interception can be a presentation of actually HSP, you should speak to the surgical team. Now, how do you actually follow up these children? If this child is well, it gets discharged. Normally, what gets done is you basically bring them back within like a week's time. You examine them, you do a blood pressure, a urine dip. If everything is normal, then each sort of unit should have their own actual template or sort of pro forma to go forward. So if the urine dip is normal, if actually normal sort of intensive, you write to their sort of GP and could you follow up this child in their sort of can be followed up at their surgery with actual a urine dip and an actual blood pressure for 1 month, 3 months, 6 months, and then basically yearly after that. And if there's any evidence of proteinuria, if there's any evidence of hypertension, then they should be referred back to the general pediatric team, which can then speak to their local sort of tertiary team if needed. If within sort of and then you should bring them back in a month's time after the initial week. How long do you follow the child up after the year? That's debatable. I think we're still sort of suggesting that basically they should be followed up yearly. And the reason why is that even though the outcome is the majority of children will have a self-limiting disease, and the symptoms tend to resolve within a month, and over sort of 90% of children will have a complete remission within sort of two years, but you will get an actual recurrence. So HSP will recur in roughly a quarter of the patients. It's more common in the older children and those with renal sort of involvement, and unless there's sort of severe neurological involvement, they do very well. And early sort of morbidity tends to relate to pain, which is mainly joint pain and GI pain. And the late morbidity almost exclusively is renal in nature, which is basically why we do the sort of blood pressure and urine dip. And the reason why we do that, because even though it does have a good outcome, roughly about 1 to sort of 2 sort of percent of sort of end stage renal disease is due to HSP. So we do want to identify those sort of children early, follow them up, and basically treat them. So take home message: HSP tends to be a self-limiting disease. Remission is normally within 6 sort of weeks. Long-term morbidity usually is almost exclusively associated with renal involvement, and it tends to manifest within sort of three months. And the majority of cases can be followed up in primary sort of care with the actual general sort of pediatric team input if needed, and then very rarely with sort of tertiary team input needed as rarely. I know that was very quick. I was only told to do a five sort of. And yeah, I can go back to the initial investigations. Yep. Do you have any questions with the initial investigations?
Yeah, sorry, I had a very quick question. Thanks, Martin. That was really good. Actually, it's really nice to get a snapshot for me. As a reminder, it's rare that I see it from, because I'm usually in an oncology setting and now going into general peds again. So this is really good. In terms of any immunological tests, would you do anything initially for these kids?
I wouldn't do anything. I wouldn't do anything actually initially, unless there was something, you know, in the actual history, in the actual blood results, and said, you know, that's basically leading me this way. But this basically is basically a clinical sort of actual diagnosis, HSP. So unless there's something, you know, glaringly saying, or glaringly in the actual initial sort of results, I probably would just say, you know, because most of these is sort of the actual full sort of blood count has to be normal. You might have slightly, it usually precedes a viral infection, so you might have a slightly low lymphocyte count, but otherwise sort of normal. The user needs are normal. If the renal function is abnormal, then you would speak to the actual renal sort of team. The clotting tends to be normal. If it isn't, it tends to be another sort of actual diagnosis. The other question I have: what is the role of steroids? Steroids can be used. They're usually used in sort of when the sort of abdominal pain is sort of actually severe, but most of the pain tends to sort of respond to simple sort of analgesia. And simple sort of analgesia is just paracetamol, ibuprofen. I, being an actual nephrologist in training, I basically will check the renal function before I give them sort of ibuprofen. And so someone asked, is ASOT a complement not needed? If you're basically thinking that this is, if you're thinking this is an actual nephritic picture, then you can. You have to basically just tailor your sort of actual investigations to the actual child who's sitting in front of you. Many times if they come with the actual purpuric rash, they come with, you don't have to send very many investigations. And someone asked you want to know the formula again. So the formula we use at the Evelina is 30 times the height divided by the serum creatinine, which gives you a rough sort of EGFR.
Martin, can I just add one more thing, just with my oncology hat on? One of the things that I do routinely have done routinely for these kids is I've always done a blood film, because we've been caught out a couple of times with kids who, I mean, it's one of those classic presentations of quite a bad oncology presentation. So often your FBC and clotting are also deranged, but just it gives you an early sign if the blood film's got blasts on it. So I'll just add that on my 2 cents. And thank you for answering the previous question.
Oh no, I think it's a really good point. I think any sort of child with a sort of wide sort of spread purpuric rash should just have a film done for sort of completeness sake, because you will really catch something that, you know, something that nasty, and if you you know, and you can't sometimes delay sort of the actual diagnosis. They'll come back a week or two later.
Yeah, thanks very much.
Okay. Excellent. Thank you very much. There's another question on sort of start steroids for severe joint pain versus severe abdominal pain. I've never seen it started for severe joint pain, and I've only seen steroids given once for abdominal pain, and it was literally a short course. We didn't wean. We just gave, I think we gave basically three doses of steroids, and it didn't really help. What ended up helping was basically they ended up on they ended up with the surgeons, and they ended up with a little bit of morphine, and the pain sort of resolved after about 3 days, I think. Okay, thank you very much.